1. Allergies and skin problems. A 4-year placebo-controlled clinical study published in 1993 found aspartame and its metabolites induce hypersensitivity reactions such as urticaria or angioedema on the same level as placebo. The adverse reactions after aspartame or placebo appeared with the same frequency at all doses. A double-blind randomized crossover study in the United Kingdom compared a group of sensitive individuals with self-reported hypersensitivity and a group of non-sensitive individuals. The individuals were administered snack bars either with or without 100 mg of aspartame, with at least a 7-day break between administrations. No differences in the responses to either bar were found between sensitive and non-sensitive groups, indicating no adverse effects associated with acute ingestion of aspartame. Some studies suggest that consuming aspartame could result in the development of skin problems. Systemic contact dermatitis (SCD) appears when a sensitive individual has contact with an allergen via cutaneous or systemic route. Aspartame can induce contact dermatitis, manifested by skin inflammation, and this has been attributed to an accumulation of formaldehyde, that is a metabolite of aspartame. However, daily aspartame intake must be huge to induce formaldehyde accumulation. Such effects have been observed in both adults and children. For example, in an 11-year-old patient who suffered from generalized erythema and eyelid dermatitis, discontinuation of an aspartame-containing drug mitigated both symptoms. Similarly, in the case of a 60-year-old patient with a 6-month history of eyelid dermatitis, the symptoms completely resolved within 1 week of discontinuing an aspartame-based sweetener. A formaldehyde releaser is a substance that releases formaldehyde during its metabolism or under different condition. Well-known formaldehyde releasers are quaternium-15, imidazolidine urea, diazolidine urea, DMDM hydantoin, and 2-bromo-2-nitropropane, 1,3-diol, TRS and hydroxyethyl, hexahydrotriazine, formaldehyde resins. It is possible to meet these substances in clothes, adhesives, paints, lacquers, cosmetics, toiletries, and household products. After exposure, formaldehyde-sensitive individuals typically suffer from lesions of the mouth, eyelids, and skin, as well as gastrointestinal disorders. At concentrations of 25, 50, and 100 mg per kilogram, aspartame has similar analgesic and anti-inflammatory properties to non-steroidal anti-inflammatory drugs, NSAIDs, such as aspirin. At a concentration of 10 umkg/1, aspartame increases IL-10 production and decreases IL-6 production. Even though there is no proof that aspartame has anti-inflammatory effects, it may inhibit prostaglandin H2 synthesis and inhibit cyclooxygenase. Atopic dermatitis (AD) is a kind of inflammatory skin disease which is chronic and relapsing. AD is characterized by pruritus, dryness, edema, lichenification in skin lesions, and erythematous. AD has a difficult pathogenesis comprising genetic, immunological, and environmental factors. It has been found that 0.5 per kilogram and 0.5 mg per kilogram doses of aspartame inhibited ear swelling, one of the symptoms of AD, and suppressed infiltration of eosinophils to skin lesions, degranulation, and epidermal thickening. T lymphocyte level also has a considerable influence on the development of AD symptoms. Aspartame suppresses infiltration of CD4 plus T lymphocytes in skin lesions and inhibits the formation of skin lesions by inhibiting synthesis of inflammatory cytokines caused by activated CD4 plus T. There are 2 phases during AD. In the first one, T helper type 1 dominates, and symptoms occur due to the production of IL-2 and IFN-gamma by Th1 cells, resulting in a chronic phase, and the development of hyperkeratosis and dermal thickening. In the second phase, T helper 2, Th2, is dominant and produces IL-4, IL-5, and IL-13. This kind of AD manifests as an increased level of IgE and an accumulation of inflammatory cells in the skin lesions. Eventually, symptoms of chronic AD occur. Aspartame in concentrations of 0.5 mg per kilogram and 0.5 mg/kg1 alters serum IgE level,